Bedside assessment of the patient. Decisions regarding when to initiate, change, or discontinue therapy depend upon accurate clinical assessments. Ultimately, physicians are responsible for these decisions. However, because respiratory therapists, RTs, often participate in clinical decision-making, they must develop competent bedside assessment skills. To do this effectively, the RT must assume responsibility for gathering and interpreting relevant bedside patient data. Bedside assessment is the process of interviewing and examining a patient for signs and symptoms of disease, as well as evaluating the effects of treatment. Often, it provides initial evidence that something is wrong. In contrast to some diagnostic tests, bedside assessment techniques have little risk to the patient. Two key data sources are the patient's medical history and physical examination. This data helps identify the need for subsequent diagnostic tests. After a tentative diagnosis is made, assessment skills are used repeatedly to help the clinician select the best therapy, monitor the patient's response to therapy, and make any necessary adjustments. The patient initially is assessed to identify the correct diagnosis. Diagnosis, from the Greek to know thoroughly, is the process of identifying the nature and cause of illness. It is a systematic approach based on careful history-taking, physical examination, and testing, for example, laboratory analysis of blood, radiologic examinations, etc. Differential diagnosis refers to a situation when many diseases share the similar signs and symptoms, making their exact cause unclear. Therefore, differential diagnosis is the list of all possible causes of a symptom or sign. For example, a cough can be a symptom of a common cold, pneumonia, bronchitis, or congestive heart failure, CHF. Signs refer to the objective manifestation of illness, for example, increased respiratory rate, heart murmur, whereas symptoms refer to the sensation or subjective experience of some aspect of an illness, for example, breathlessness, cough. Symptoms must always be stated by the patient and never inferred from observed signs. Common symptoms and signs associated with cardiopulmonary disease are discussed in this chapter. Diagnosis is performed primarily by a physician. Exceptions may occur in emergency situations when a physician is unavailable. In such cases, nurses and RTs may evaluate the patient to rapidly implement appropriate life-saving therapy, for example, cardiopulmonary resuscitation, CPR. The mastery of bedside assessment skills described here requires practice. Initially, students should practice these skills on healthy individuals to improve their technique and appreciate the existence of normal variations. The ability to discriminate abnormal findings from the range of normal findings is important and requires deliberate practice and experience to master. Interviewing the patient and taking a medical history. Interviewing provides unique information because it represents the patient's perspective and serves the following purposes. 1. To establish a rapport between the clinician and patient. 2. To obtain information essential for making a diagnosis. 3. To help monitor changes in the patient's symptoms and response to therapy. Principles of interviewing. Interviewing is the process of gathering relevant information from a patient, an essential element of which involves establishing rapport. Rapport building requires basic human skills of communicating concern, warmth, and empathy. Illness serious enough to require hospitalization is always stressful. Meaningful human contact lessens a patient's sense of isolation and helps reduce stress. Factors affecting communication between the RT and the patient include the following: sensory and emotional factors, environmental factors, verbal and nonverbal components of the communication process, cultural values, beliefs, feelings, habits, and preoccupations of both the RT and the patient. These factors make every interview unique. Developing interview skills takes practice and experience. It requires adherence to basic techniques and acquiring knowledge about the causes and characteristics of common cardiopulmonary symptoms. The following discussion provides some guidelines for interviewing and discusses common symptoms associated with diseases of the chest. Structure and technique for interviewing. An effective interview makes the patient feel secure enough to talk openly about important personal matters. Each interview should begin with the RT introducing himself or herself to the patient and stating the purpose of the visit. Introductions are done from a social space of 4 to 12 feet from the patient, which is considered socially appropriate between strangers and therefore non-threatening. The perception of appropriate space varies across individuals and particularly those of different cultural backgrounds. In some cultures, for example, it is inappropriate for men to shake women's hands. So cultural attentiveness and competence is important. Creating a sense of privacy, for example, by pulling the curtain between the beds of a semi-private room, helps the patient feel more at ease with the interview. Ch.16. After an introduction is made, it is usually appropriate to begin the interview from what is referred to as personal space, 2 to 4 feet from the patient. This allows the interview to occur with a normal or soft-speaking voice and creates a sense of discretion and intimacy needed for disclosing personal information. Rapport is further established by positioning yourself at an equal level with the patient, for example, by sitting in a chair. Standing over the patient may cause them to feel intimidated and uneasy. Appropriate eye contact with the patient is essential for a high-quality interview. Carefully observing nonverbal behavior during an interview, for example, facial expressions, stiff or relaxed posture, etc., may hint at a patient's internal state such as fear, frustration, or even relief. A related aspect of observing a patient during an interview is their perception of appropriate eye contact. What is considered appropriate varies between individuals and across cultures. Direct eye contact may give the patient more confidence in the interviewer. However, prolonged eye contact also can feel intimidating and in some cultures is considered rude. Therefore, the interviewer must be constantly sensitive to how a patient responds to the interviewer himself/herself. Avoid asking leading questions and instead inquire using a non-directional neutral style. For example, asking the patient, "Is your breathing better now?" subtly leads the patient toward a desired response. For example, "My therapy is helping you, right?"